Management of periampullary carcinoma. Periampullary carcinoma refers to tumors originating from the ampulla of Vater or its vicinity, including the distal bile duct, pancreatic head, and the second portion of the duodenum. It has a more favorable prognosis compared to pancreatic cancer due to earlier symptom onset, typically jaundice. Management requires a multidisciplinary approach, including surgical, medical, and supportive care. Diagnostic evaluation. Accurate diagnosis and staging are critical for management. Clinical presentation: obstructive jaundice, dark urine, pale stools, abdominal pain, weight loss, and pruritus. Laboratory investigations: liver function tests, elevated bilirubin, alkaline phosphatase, and gamma glutamyltransferase, GGT. Tumor markers: CA19-9 and CEA, elevated in some cases but nonspecific. Imaging: ultrasound, UST, initial assessment for biliary obstruction. CT scan, triphasic, helps assess the tumor, vascular involvement, and metastasis. MRI, MRCP, better delineation of biliary and pancreatic ducts. Endoscopic ultrasound, EUS, for detailed local staging and biopsy. Endoscopic retrograde cholangiopancreatography, ERCP, diagnosis and palliation of biliary obstruction. Stent placement may be performed. Biopsy histopathology confirms diagnosis, often obtained via EUS or ERCP. R2. Staging. TNM classification by the AJCC, by the 8-ACE-T, tumor size and invasion into surrounding structures. N. Presence of regional lymph node involvement. M. Distant metastasis. Staging determines whether the tumor is resectable, borderline resectable, or unresectable. 3. Management options. A. Surgical management. Curative intent, resectable tumors, pancreatic duodenectomy, Whipple procedure, gold standard for localized periampullary carcinoma, involves removal of the pancreatic head, duodenum, gallbladder, and bile duct, followed by reconstruction. Pylorus preserving pancreatic duodenectomy, alternative preserving gastric function. Lymphadenectomy, essential for proper staging and prognosis. Adjuvant therapy, post-surgery, chemotherapy, or chemoradiation is recommended to reduce recurrence risk. Common regimens: gemcitabine-based or fluorouracil-based therapy. TAR B, palliative management, unresectable metastatic tumors, endoscopic or percutaneous biliary drainage, relieves obstructive jaundice and improves quality of life. Metal or plastic stents may be used. Chemotherapy. Palliative regimens include gemcitabine alone or in combination, e.g. with cisplatin or capecitabine. Radiotherapy, symptom control, especially for pain or local tumor effects. Pain management, opioids for severe pain. Celiac plexus block can be considered for refractory pain. C. Borderline resectable tumors. Neoadjuvant therapy. Chemoradiation may shrink the tumor to enable surgical resection. 4. Supportive care. Nutritional support. Address malnutrition due to biliary obstruction and malabsorption. Pancreatic enzyme replacement for exocrine insufficiency. Psychosocial support. Counseling and palliative care support for patients and families. Infection management. Monitor for cholangitis in patients with biliary stents. 5. Follow-up and surveillance. Routine follow-up every 3 to 6 months. Clinical evaluation for recurrence or metastasis. Imaging studies, CT, MRI, monitoring tumor markers, CA19-9, CEA. Prognosis. Overall 5-year survival depends on resectability. Resectable to 40 to 50% in early stage tumors. Locally advanced metastatic, poor, with survival 1 year without treatment. Management of periampullary carcinoma is complex and necessitates an individualized treatment plan tailored to the tumor's stage, patient's performance status, and preferences.